So we'll get started and just thank everybody for joining us for this webinar, which is the sixth and final one in our series on the role of artificial intelligence in family medicine. And we're really pleased to be joined by some fantastic speakers today. And our focus is going to be on social ethical considerations around AI in primary care. My name is Andrew Pinto, and I'm a family physician, a public health specialist and scientist at the University of Toronto, and I have the pleasure of directing the Upstream Lab. I'm also a lead for artificial intelligence efforts at the Department of Family Community Medicine as well, and I've been the host for these sessions. I'm really pleased to be joined by three outstanding speakers today. We have Dr. Melissa McCradden, who is a bioethicist at the Hospital for Sick Children. She has a PhD in neuroscience and a master's in bioethics. And she has a particular focus on this topic of really thinking through the focus of AI in healthcare and the ethical implications. We also have Dr. Carolyn Steele-Gray, who is a scientist and a close colleague of a number of years. She is at Bridgepoint Collaboratory, as well as the University of Toronto. And she has a particular interest at how technology is shaping healthcare and kind of what we can think about for the future. And then we have Dr. Azza Eissa, who is a family physician, recently finished her residency training. She has a PhD in the basic sciences. She has a number of areas of interest and focus. She is completing a fellowship in journalism. She is going to be starting at the Institute for Health Policy Management and Evaluation in the fall. And she is really an emerging leader in primary care research. And we're really privileged to work with her at the Upstream Lab. So just as is now traditional in Canada, we want to just begin with a land acknowledgement. We are currently in Toronto, located on traditional land of the Huron-Wendat, the Seneca, and most recently in the Mississaugas of the Credit River, and are very grateful and feel honored to be living and working on this land. And also note that, of course, this is still home to many people from across Turtle Island who call it home. And whenever we do land acknowledgements, we want to use the opportunity to also amplify the work of colleagues and folks in the Indigenous community. This is one resource which Dr. McCradden identified and which we had come across as well, which is a protocol from Indigenous colleagues around artificial intelligence, and really encourage people to take a look at the link and look at the really amazing report and set of guidelines that has emerged. So just a few other items for all of this, these webinar series. These are the objectives overall. So to look at the anticipated impact of artificial intelligence tools on the practice of family medicine, particularly on clinical decision-making, to be aware of how to engage your team or organization and patients and vendors around the fit and their performance, and also to talk about key concerns for communities that have been historically made vulnerable by social and economic policies, including areas around data ownership and governance and privacy. These are my notes around disclosures. I don't receive any specific funding from for-profit or commercial entities, but have received research funding from a variety of sources and salary support. And one note is I serve as an unpaid advisor to a startup company as well. These are disclosures for Dr. McCradden and then for Dr. Steele-Gray, and then also for Dr. Eissa as well. So I'm going to turn it over to Dr. McCradden to get us started, and each presenter will present for roughly about 10 minutes or so, and then we will have a lot of time for questions as well.
Okay, thank you so much for having me today. So I'll be talking about how to make good decisions for patients using AI. We'll cover a lot of ground, which my colleagues will elaborate on in the next sessions. So here I'm defining a good decision as one where we are practicing evidence-based medicine. We are protecting patients' best interests in their autonomy, and we're practicing equitable healthcare. So I take it as a given that a lot of us see the value of AI. We're seeing this emerging more and more. And so I'd like to say, I take it that all of us accept the value of AI. What I'd like to focus on today are the risks and the potential harms. And so this has really been identified as stemming from a gap between the cultures of machine learning science and the norms of evidence-based medicine. So this is a really fantastic paper that I recommend to everybody to read, which really does a great job at highlighting how there is this gap between the methodology that we're familiar with in science, so randomized controlled trials, quasi-interventional trials and observational studies, versus those of computational sciences. And so this study identified that there's been an inadequate scrutiny of the methodology and insufficient adoption of scientific good practices. And I'm happy to say that I think we're making a lot of progress on this. There have been new reporting guidelines, some of which I'm involved with, that are coming out, trying to integrate these two cultures of machine learning with evidence-based medicine. And really that's the goal, because ultimately, as practitioners of evidence-based medicine, you want to ensure that you're making good decisions for your patient by drawing from high quality evidence. And so what exactly counts as evidence is one of the core questions that we're grappling with right now as we integrate machine learning into healthcare. And importantly, evidence is not the only part of that picture. We also have clinical expertise. So in your own experience, in your own practice, you may see particular patterns or develop a sense of intuition, and that's valuable as well. And ultimately, we're all guided by the overarching framework of patient autonomy, patient values and preferences, which recognizes that sometimes the practice of medicine involves treating the patient as a person, which may involve looking to more than just how to treat them best medically. So in an effort to try and bridge the gap here and move AI research toward the evidence-based medicine paradigm, my colleagues and I developed this pipeline that we use at SickKids, which involves 3 stages. And really what it considers is that there's a plethora of types of evidence that are involved across the life cycle of AI. So we consider how this is analogous to the traditional RCT pyramid. And so at the very bottom, we have retrospective studies. So these are studies where a model may be developed in an historical data set. This is overwhelmingly where you hear, model accuracy of 90%, somewhere around there. And importantly, we need to know that this is actually where the majority of machine learning research sits right now. And the kind of evidence that that kind of demonstration of science provides is a theoretical plausibility that a certain outcome can potentially be predicted using AI. Now, the next step is that we need to see whether that model is actually going to hold true in a live environment. There's a lot of differences between models developed in historical data sets versus those that are trying to take in incoming real-time patient data. And so we do an observational study, otherwise known as a silent trial or a shadow evaluation, to first test whether the model is actually going to work in that environment. And so this is a non-interventional prospective study whereby the model predictions are interpreted by a research team. They don't reach the clinical team. And we're correlating them with real-world outcomes or other on-the-ground evaluations, such as molecular confirmation of a diagnosis or biomarker confirmation. And this is really where we get the first sense of the potential clinical utility of the tool. But still, what it doesn't tell us is establishing any facts about that model's use on patient outcomes. And for that, we need the 3rd stage of research, which is the 2nd and 1st level of the pyramid here. And this is prospective clinical research. So we can have quasi-randomized studies such as stepped wedge and others, and then we have the full randomized controlled trials, which provide the highest level of evidence, but are not always feasible in some contexts. And so essentially what those prospective studies allow us to do is establish facts about the model's use as it impacts patient outcomes. And so one of the examples that was on the screen earlier was of IDXDR. So this is a system which detects diabetic retinopathy in a primary care office. And so they have done a very large observational trial, which has demonstrated that the model has very, very good accuracy at identifying diabetic retinopathy at the point of primary care where an ophthalmologist may not be present. And so that's a really good thing. It tells us that the system works with respect to that particular outcome. What we don't necessarily know is whether identifying diabetic retinopathy at that point in the clinical pathway is associated with a net benefit to patients. And we know in other contexts that overdiagnosis and patient anxiety or inefficient use of healthcare resources all are implicated in how good a technology is or isn't. And so others have said that, well, maybe what we just need to do is understand the predictions. And so explainability has been a means to try and address this accountability gap, whereby an explanation is a means to account for an individual prediction. So explanations are supposed to tell a clinician why a prediction was made about a given patient. However, there's some big caveats when contrasting what we know with explainability versus the knowledge that we gain with prospective evidence. And one is that explainability may actually exacerbate automation bias. We may be more likely to overtrust when an explanation is present versus not. It decreases our likelihood of detecting when the AI system may make a mistake. And it may also decrease clinician baseline accuracy when there's an incorrect prediction. So clinicians might have made a better decision without the AI than with the AI when that AI is wrong. And this is really important because the current state of computational science is such that our methods right now can't actually reliably provide a causal account of individual predictions. So what's really happening is we have no means of differentiating whether the explanation provided by the model is something that is important to the task generally, or whether it's telling you something about this individual patient. And so when we think about accountable decision-making being something that is patient-centered, that gap is really important. And so at the current state, explainability has a bit of a long way to go in order to provide us with a robust foundation for accountable decision-making. And it's important to recognize too that the risks of model mistakes are not equal to all patients. So this is a well-known example, and I know Dr. Eissa will elaborate on the implications of fairness later on. But just to highlight this really prevalent example now, this was a commonly used algorithm in the United States. It was used to allocate patients into a complex care treatment program. And so it was purportedly race neutral. The developers had removed race from the algorithm's training. And so supposedly it was neutral with respect to race. However, when digging into the system, they found that actually Black patients were twice as sick as white patients at the point when they were referred to care. And so Dr. Ruha Benjamin has noted that it is really important to not assume that algorithms are capable of neutrality or objectivity, because when we assume that, very often we underestimate the risk to patients. So some people have thought, well, if algorithms are biased, maybe we can correct this with algorithmic fairness. And so my colleagues and I looked at this in a paper in Lancet Digital Health, and we found that even though these are often treated as technical choices, so how do we make model outputs look the same across different patient subgroups, what we think is that really this is a profoundly ethical question, which involves complex knowledge about how those patterns are generated and how the system is actually going to be evaluated. Because ultimately, we can't know if we're providing care that is equitable based on a model outputs alone. We need real world evidence about the actual impact to patients as a result of that model use. And so when companies when companies are marketing tools that are purportedly bias-free or are neutral with respect to patient race, there's really good reason to be very, very skeptical of those claims and to want to see some real world evidence. So all of this is really to say that for making a good decision, clinical evidence is what tells us whether the AI intervention has a net benefit or not, for whom and under what conditions the model provides benefit, and whether or not we have actually made healthcare delivery more fair or not. So really, when making good decisions, we need to center the moral commitments of clinicians, and these involve integrating the evidence with the shared decision-making practice. And shared decision-making is really important because it recognizes that a patient is more than a patient. They're a person as well. And so other ways of thinking about what good decisions are, such as through thinking about harm reduction approaches, or allowing people to integrate their cultural values into the provision of good healthcare. These are all really important for making good decisions beyond just the evidence alone. And the accuracy of no individual system can actually override a capable patient's choice in this matter. And so just to recap, a good decision, in my opinion, is one that draws from robust clinical evidence, is reached through shared decision-making with patients, promotes equity by ensuring accountability in collecting metrics based on real-world evidence, and preserves autonomy in recognizing that capable patients are entitled to make their own choices about healthcare. So thank you very much, and I'll turn it over to the next speaker.
Thank you so much, Dr. McCradden. That was fantastic. So next, we're going to turn it to Dr. Carolyn Steele-Gray.
So today I'm going to be coming to this question from a little bit of a different angle, because I'm a non-clinician on this panel, and I'm instead an implementation scientist. So when Dr. Pinto reached out to me to sit on this, I kind of came back and said, well, is it okay if we talk about implementation? So I'd like to start actually on the next slide, please, with a quote from a close colleague of a number of us, Dr. Russ Upshur, who wrote on artificial intelligence and machine learning in family medicine back in 2019 for AMS Healthcare. And toward the end of this report, he writes, to reiterate, no one knows with any certainty how the new technologies will impact family medicine. That there will be an impact is certain. How these impacts play out could be influenced by a vast number of factors: policy contexts, political considerations, commercial interests, and increasing consumer demands will intertwine in nonlinear ways. And what Dr. Upshur is really getting at here is the notion of context. So where Dr. McCradden was talking to us about the clinical interface where AI kind of comes into clinical decision-making at that point of care and how we need to attend to that piece of the puzzle. What Dr. Upshur is saying to us here is we need to also attend to the broader context in which that interaction is occurring. And that's where implementation science can really help us unpack what these ethical and social implications may be, not just at the point of care, but from a wider standpoint and the different factors we need to consider. So on the next slide, a little brief overview if you're not as familiar with implementation science, although it's a much more widely known branch of science now these days. Quite generally speaking, it promotes the uptake of evidence in routine healthcare delivery in clinical, organizational, or policy contexts. And generally, it examines what works for whom and under what circumstances, and how interventions like AI or other digital health innovations or new models of care can be adapted and scaled up in ways that are accessible and equitable to those it's trying to reach. And it often rests on a number of theoretical frameworks and models that will point to us in the direction of domains and constructs and components of a particular, that are within or around a particular intervention that will influence what that impact is going to be. So one framework that's really often used on the next slide is the Consolidated Framework for Implementation Research. This one's used quite a bit in implementation science and has been iterated, and it points out 5 core domains that we need to consider when thinking about implementation of technology or any intervention in any setting. And what you see on the left is attention to the intervention itself and a couple of the components that Dr. McCradden spoke about in terms of how algorithms are built or how the technology has been generated. That kind of fits into that component. At the center, you see the individuals who are involved. So in this example, we see clinicians using a particular technology in place. But we also need to attend to the inner setting. So that's components about the model of care, components about the organization or the family or the team or the organization in which that technology is being placed, as well as the outer setting. So what are policy, regulations, funding models, and different regulatory structures that it can influence the way a technology is being placed. And what you see on the left is kind of this misfitted intervention attempting to kind of fit into these other components. And along the bottom, what is demonstrated is an iterative process in which you're adapting that intervention to those different components over time toward the right, where you have a nicely fitted intervention that meets the needs of the individuals, the inner setting, and the outer setting. But so the process is where things can become really important for us in being able to attend to ethical and social implications, so that once you get to an adapted technology, you're doing so from a framework that attends to ethics and social concerns. And so on the next slide, we have two different frameworks, which I have unfortunately not placed the references for, but please do email me. But what you see, to get them, on the left, you see Greenhalgh's non-adaptation, acceptance, scale, and spread model, the NAS framework. And on the right, you see the value proposition design, which was developed by Dr. James Shaw and colleagues at Women's College at Weave here in Toronto. And these are frameworks kind of help with that bottom component of the CFER framework, help with that process-oriented piece. So how do we think about those process components in terms of putting technology, AI or otherwise, into practice? And if you hit the next button for me, Andrew, what these two frameworks have in common is they place value at the center of those processes and those decisions. And they ask us to think about, what do the people, organizations, and systems around a technology value in terms of their delivery of care. And you can think about value in lots of different ways. Traditionally we think about it in terms of value for money or cost effectiveness. But another way to think about value, on the next slide, that I proposed in a commentary just published last year, is what is meaningful to all of those individuals within the model. So not just the patients, families, and communities and providers, but also to the system at large, to our teams, and to our kind of value-based systems that surround all of those processes. So we can think about value in this other way in terms of what's meaningful to all of those different individuals in the process of delivering care. So on our next slide, one of the ways you can operationalize this concept of getting at meaningfulness when you're implementing technology to attend to ethical and social concerns is we can ask, what do my patients, providers, team, and organization value in the way they access and provide service, and value in terms of what is meaningful psychologically, socially to these individuals. Then you can ask, does this technology align to those values? And that with AI goes deep into questioning the algorithm, how it's built, and how it's been iterated in order to assess whether there's alignment there. And then finally, how can we adjust our technologies, not just in terms of the technology itself or the algorithm itself, but the implementation of that technology into our process of care. And what I wanted to leave you all with is a particular method you can use that will help attend to all of these components as you're implementing a technology. So you have a new one in front of you, you want to put it into practice. How can you use implementation to become more attuned to ethical and social impacts of that particular technology? So on the next slide, I'm proposing today that you consider co-designing your implementation. So we talk about co-designing a technology, and those of you who've come from a technology space might be familiar with that. But here you can also co-design the implementation. So if you remember that process, those red circles that are iterating forward as you implement something, You can do that not from a top-down approach, but you can do that in a co-design fashion or in consultation or in a co-construction with all of those stakeholders. So in the first point around this is identifying, if you could go next for me, is identifying who your users are. And it's really important not just to think about your primary users, so the people who are actually touching the technology or impacted by it or having clinical decisions informed by it, but who are the secondary and tertiary users of the system who might not be touching the technology, but will be impacted by it. And this is where some of those ethical and social conundrums can kind of bubble up to the surface because we don't often think about those secondary and tertiary users. So start by identifying them, and next, engage them in an iterative development of your implementation. So not just the technology, but as you're thinking about putting it into practice, work with all of those individuals at multiple levels through things like working groups or facilitation to help iron out the kinks, identify potential ethical issues or social issues, and then address them as you go through putting this technology into practice. Next is identify what implementation levers you can pull at different stages. So back in the CFIR framework, the Consolidated Framework for Implementation Research, it identifies these 5 different domains, some of them sitting in the outer context, which you might not have access to change. There might be policies or regulations you're just bound by. So you need to potentially work within some bounded realities, but there will be levers you can change, and you can identify that with your key stakeholders. Next is to aim for an area of understanding and compromise rather than consensus. With so many stakeholders you need to think about in this process, it's very difficult to get to a place where everyone solidly agrees. But if you always have the aim that we're going to understand each other and we're going to land on a compromise, you're more likely to move forward. And finally, adopt a learning mindset and an inclusive approach that, as we saw in the bottom of that framework, we're always iterating forward. And although today might not be as good as we'd like it to be, if it was a little bit better than yesterday, then you're always moving in the right direction. And if you hold those values, the meaningfulness of all those stakeholders kind of center to that process moving forward, you're more likely to be able to identify and attend to some of these ethical and social concerns as you move through adopting that technology. And I'll leave it there. Thank you.
Thank you so much, Dr. Steele-Gray. That's really helpful and really great kind of set of questions for folks to try to answer as they're implementing this. I'm going to turn it now to Dr. Eissa to speak next, and then we're going to be opening up for questions. And I just want to ask folks to, if you have a question, feel free to start to put it into the Q&A box, and we'll be turning to those in the Q&A section.
Thank you, Andrew. I'm happy to join the panelists and discuss this interesting and exciting area of AI in primary care, and in particular in the future of AI in family medicine. So as the previous speaker spoke about, the future of AI is really now. And if you notice, you'll see that the AI field is expanding rapidly with over 60-fold increase from 2005 to 2019. This is by looking at the number of studies that are found on PubMed, searching machine learning or deep learning, and also looking at the specialties that have been publishing using machine learning or deep learning AI terms in their publications. It's interesting to see primary care listed. So the smaller fonts, we have sports medicine, pulmonology and respiratory diseases. We have cardiology, primary care. By far, the largest number of studies are seen obviously in radiology and pathology, because these have been traditionally used in analyzing large set of X-rays and imaging, as well as pathology reports and pathology images. However, there is a shift now in AI research where we're looking at big data mining, which definitely has a huge impact for family medicine and primary care. So family medicine, if we think of family physicians as the gatekeepers and think of our patient-centered value-based care as the framework for why we need to engage with AI, And while we all know as family physicians, we're unsure how AI is going to change the field of family medicine. We know that our jobs will change, much like our electronic health records have changed the practice over the past decade. AI will change practice. For example, just COVID-19 and having to adopt telemedicine and virtual care was an example on how our field can rapidly change with the changes that we experience as a whole. So another important aspect when we think about AI in family medicine is our longitudinal therapeutic relationship with patients. So when I think of family medicine as a research field and as an academic field, I think we are actually highly positioned in the right spot to be able to test our hypothesis and see the results and get feedback from our patients, just purely based on our experience as family doctors and our longitudinal relationships. But that also brings a huge set of challenges in terms of efficiency and time. And AI is claiming that it can help with increasing efficiency and giving us more time to build therapeutic relationships and focus on areas that matter, such as complex chronic care and diverse population group needs. The breadth could strengthen the AI tools, and by breadth, I mean the breadth of family medicine, and the fact that we have access to a huge set of data across not only organs, but delivery systems, mental health, home health, public health, also make family medicine an important aspect for AI, and our involvement will rapidly increase in the future. So I want us to focus a little bit on the ethical consideration. And I think this documentary that is actually going to be on Netflix is an important aspect that we need to address. So Andrew, are we able to, I'm just gonna show the trailer.
During my first semester at MIT, I got computer vision software that was supposed to track my face. It didn't work until I put on this white mask. I'm thinking, all right, what's going on here? Is it the lighting conditions? Is it the angle at which I'm looking at the camera, or is there something more? That's when I started looking into issues of bias that can creep into technology.
Our ideas about technology that we think are normal are actually ideas that come from a very small and homogeneous group of people.
Vast amounts of data at incredible speeds.
Everybody has unconscious biases, and people embed their own biases into technology.
This kid got stopped as a result of facial recognition misidentification, and then used that as justification to search you. This is an innocent child.
Racism is becoming mechanized.
Systemic issues are only going to be hardwired into new technologies.
It's not just face classification, it's any data-centric technology.
Every day, we are all being scored.
Who gets hired, who gets housing.
I am making predictions for your life right now.
The people who own the code deploy it on other people, and there is no accountability.
Management analytic towers wanted to install the facial recognition software. Pretty much turn this place into Fort Knox.
The technology is being rapidly adopted, and there are no safeguards.
We are socially controlled in a way that we don't see.
Technology that analyzes faces could be biased, but the company is pushing it anyway.
What demographic is it most effective on?
White men.
Show me that it's going to be fair, that it's legal, before you put it out. That's what we don't have yet.
It's going to take people coming together, striving for justice in this age of automation.
So I think this pretty much summarizes many of the ethical concerns that a lot of our patients and the public at large has when it comes to AI and its use. And it's interesting looking at the literature and seeing the different attitudes of patients versus providers when it comes to AI use in healthcare. And I'll talk about that a little bit next. So how could AI historically or harm historically disadvantaged populations? The fact is, the starting point for artificial intelligence always and will always be human intelligence. So Similar to humans, machines can be discriminatory, they can be racist, they can be sexist. And the lack of diversity in having AI developers who are developing the code and analyzing the code, and data annotators will contribute to judgmental data sets and AI biases in healthcare. So there will be a lot of scrutiny when it comes to the questions asked. Is there a bias in the questions, bias in the data being collected, bias in the analysis and application? And is there actually a biased cultural storytelling and narratives that are worsening inequity? So we need to focus on the regulation, the privacy and the accountability as well when we are promoting AI in healthcare. So the privacy issue, the data can come from healthcare institutions or from individuals. Even if institutions make the data anonymous, it can be proven, and it has been proven that in many cases, the individual profiles can be traced back. There has been reports of lawsuits that are related to secondary data use without consent, some in Canada and some in the United States. And the issue of liability and accountability is important. So it's important for us to think of, is the process of coding inclusive? Who codes matter, how we code matter, why we code matter. And this is an ongoing debate about who will be held liable in the future when the robots and AI act autonomously, but end up harming our patients. Now, the interesting aspect of this issue is the fact that actually many studies, and they're recent, have shown that the public is ready for AI use and point of care and using their phones and Apple Watch, etc., to manage some of their symptoms and record and be more health literate. There is a study that was published in the Journal of Medical Internet Research that showed that generally there is a positive attitude in the use of AI in medical care. They looked at social media data sets or data analysis that showed that the only concern amongst the negative views seen in the public is about the lack of trust in AI and the fact there is absence of human factors in AI. However, the majority of the public attitudes were positive compared to physician attitudes regarding to AI, which were largely negative. Some of the comments on Twitter talked about practitioners that they should pay more attention to humanistic care and try to meet patients' emotional demands rather than only focusing on the technical issues of AI. And this recent publication came out in the Lancet Digital Medicine last month. And it was an interesting paper to look at. I invite you all to look at it and read it, because it's one of the few papers that looked at artificial intelligence where AI was used to compare, traditionally it's usually being used to compare the doctor's performance. So we look at x-rays or we look at other methods of diagnostic accuracy and then compare if the machine is as accurate as the doctor performance. And this increases the two meaningful aspects of efficiency and diagnostic accuracy. However, in this paper, they looked purely at how AI can predict patients' pain, which is an area that is very difficult in medicine and in family medicine, how the radiology findings many times don't correspond to the patient's knee arthritis pain. And by using AI, they were able to characterize patients' pain more accurately. And this brings another aspect of how the pain gap in research and how AI can help, as a matter of fact, get patients into surgery. In this paper, they were able to get Black patients into surgery who were not able to get basically to meet the criteria for surgery for knee arthritis because their radiological findings were not consistent with their pain. And the factors that they use in the AI development included social determinants of health, and we all know stress contributes to pain and other factors. So this brings again this aspect of, can AI link some of the unexplainable findings that we're unable to answer and help us stratify patients better? Because based on our scoring systems that are created from the 60s and 50s, they were all used on patients who were just homogeneous group of control patients. And we may able to counteract the bias in AI by helping patients who are historically disadvantaged. So it's not all black or white. AI could help in stratifying patients, but we need to be able to ask the right questions and make sure that the right people and collaborations are involved, including patients, including computer scientists, including physicians in the process, and in question formulations that are not just physician focused and accuracy focused and diagnostics focused, but also impact and clinical outcome focused. So in summary, we really need to think about a lot. It's an emerging field. The creation of ethical standards, which are applicable and obligatory for the whole healthcare sector, need to be clearly identified and defined. We need to think about problem formulation and human judgment in the problem formulation. Education, whether it's medical education during medical school, residency, early trainees, but this is important as the development and application of AI rapidly expands. For medical professionals, we need to think about how we can find time to have basic knowledge of how AI can function in a medical setting beyond the EMR and beyond increasing the ability to access patient results. Liability and privacy is important. And for patients, getting accustomed to artificial intelligence, which it seems like patients are getting accustomed to it faster than us and discovering its benefits. And for decision makers, doing all the necessary steps to be able to measure the success and effectiveness of the AI in the healthcare system. And it's also important to push towards upholding the ethical standards and offering equitable AI solutions. So I'll just leave you with the fact that big data and artificial intelligence will revolutionize healthcare, but hopefully in the right direction. And to realize the potential of AI, more fundamental issues need to be addressed. Who owns the data? Who is responsible for it? How will it be used? And who can use it? And cloud computing alone will not answer these questions. The public discourse, the role of family physicians as gatekeepers, and policy intervention will be needed. Thank you for your time.
Thank you. And I just want to thank all of our speakers, Dr. McCradden, Dr. Steele-Gray, and Dr. Eissa for providing your thoughts. Really, really helpful. It's been a real wonderful resource, and I encourage folks to take a look at the other sessions and stay tuned for more as we move from these webinars to launching something called the Deep Network, which is to continue the conversation, engaging people in Canada and beyond around discussing how AI is shaping primary care and what direction it should go. So thanks everyone, and have a good rest of your day.